Welcome to the HST eChart tutorial for an orthopedic chart. When you log into the chart, you are brought to the home screen. The home screen consists of several tabs. The first tab is the current visit summary. The patient's visit summary will complete automatically as the patient moves through the continuum of care. It will record all medications administered during the stay, their home medications, their vital signs throughout the stay, their allergies, their in-house lab results, their problem list, and any documents that have been attached. In this case, the document attached is a history and physical. In eChart, whenever you have a document display block, the history and physical is a link. The link will open in a new browser window. In that browser window, the user will be able to read the H&P and toggle easily back to where they were in the chart without losing their place. Again, wherever the document is displayed, the link will be displayed with it. In the header, you'll notice a few things. First of all, HST is browser-based. So anywhere that you can get to a Chrome browser, you can log in to HST eChart. Once you're logged in, the user's name will appear up here in the upper left corner, along with the name of the surgery center you are currently logged into. On the right, you have an icon to get you back to the home page. You have an administration icon if you have permissions for it. You have tools which will help the public patient display, and the user preferences, and the help files, as well as your logout button. The header of the chart remains the same, regardless of where you are and where you are documenting. It will allow for you to put an image of the patient in the upper left corner. This is important because HST allows a user to have multiple charts open at the same time and allows multiple users in the chart at the same time. But if you have multiple charts open, you'll always know with confidence that you're charting on the correct patient because their image will be in the left corner. You have the patient's name, their demographics, the anesthesia, the physician, the primary physician, and the procedure. You'll also have some banner alerts. These happen some automatically as certain things are asked and answered, but the H&P but the consent banner alert will disappear once all of the consents have been signed prior to the start of the procedure. In the far right, you have a print icon. Any part of the chart, page of the chart, or workflow will be able to be printed. The push pin allows you to toggle back and forth quickly between the areas of the chart that you're in, or multiple patient charts as we discussed. And in the far right, you have the completion indicator. This indicator will show you how complete any parts of the chart are as you move through the continuum of care. Some parts of the chart will be completed before a user even enters it. For example, in this case, the document display came in along with it partially completing the H&P attestation. But we'll see that when we get to the physician workflow. HST eChart is divided into workflows, and that is so that each user is able to stay within their workflow to complete all of the required documentation. They don't have to navigate anywhere else to make sure that they've completed everything that they need to do to document on this patient. So let's proceed as if this is the day or several days before surgery, and we're going to complete the pre-op phone call. HST is divided into a series of blocks. Each of these blocks contain a small amount of data. They can be stacked in any order that you choose. They can be used or not used depending on the case specialty type and what needs to be documented for that case. Every block is equipped with a completion indicator of its own. This indicator not only tells you the block is not complete, But when you tap on it, it will tell you exactly what is required to complete this block. In this case, either NA must be checked, a grid row must be entered, or unable to contact the patient must be checked. Let's go ahead and add a grid row. You'll see the primary language defaulted to English, but you can absolutely change that. This is a search field. In the flyout, we're going to enter the time that we put in the call. To perform that call, this button will always enter the logged in user's information, so you never have to search for yourself. Then you have several statuses to report. You could say it's partially complete, or you left a message, or there was no answer. In this case, we're going to go ahead and complete the call. You'll see that we spoke with the patient in their primary language is pre-selected for you, as that is the most common answer. However, you can always edit the answer should you feel the need to. Once you complete the required data, you're going to get your green check mark. This grid will also tally how many communication attempts you made before you were able to reach the patient, or before you were able to not declare that the patient is unable to be reached. The next block is called patient information. This information comes directly from practice management, from the scheduling and the registration demographics. If you change information in this block, it will change the information in practice management as well. Now you can see I made the gender identity selection. That is now in the demographics header of the chart. If I put in a preferred name, that preferred name does not appear on the header, as that is printed as part of the legal chart, but it will always appear. Let's give Lucy a middle initial of M, and you can see that M will appear in the header immediately. And she goes by her middle name, Mary. Lacey's preferred name is now in the I block, where you'll be able to see what her preferred name is at all times. The information in the I block is available regardless of whether you're in a flyout or in any part of the chart. That is always available to you. Let's say she does not want to disclose her email, and we're going to put in a cell phone number for her. So any information that you put in here will parse back, so there's no duplicate entry. eChart tries not to have anybody have to duplicate entry information, only confirm it as the case may be. I'm going to go ahead and put in an address so that we can see another feature that's coming up in the next block. We're going to say that the patient has an allergy to sulfa, and it's a true allergy, and she gets a rash of moderate intensity whenever she takes this medication. Behind the scenes, as soon as you enter the patient's allergies, the system will do a med allergy check for all ordered or potentially ordered medications throughout the chart. But this is not a one and done process. Anytime an allergy is added or edited, when a home medication is added or edited, or if a new order for medication is placed within the chart, the system will repeat the drug allergy check. So it's always doing that for you in the background. In the home medications block, we have partnered with a third-party application called DoseSpot. DoseSpot will assist your clinicians in bringing in a 12-month history of the patient's prescriptions. You have to get the patient's permission to pull in their history, but once you have, you're able to import from DoseSpot. Now, this is a made-up patient, so there is no spot information to import, but that gives me an opportunity to show you how to add manually into the home medications. So I'm going to look up a very common medication, Lipitor, And I'm going to say that the patient knows that they take one tablet, but they don't really know the dose and they take it every day. And we're going to save that. For the system to do its drug allergy check, you really don't need to know the dose, the exact dose for it to work, but you may want to be able to have that information. If you pulled it in from DoseSpot, it would fill in all of the required information. This next block is called a patient history block. It's a questionnaire. Your center gets to design this questionnaire with our assistance, and you'll be able to edit it at any time. We give you the tools and we give you the knowledge. But this is how you can ask information and questions that your team wants the answers to that pertain to any specific case or case history. In this case, we're going to make sure the patient isn't taking any medication that could affect their bleeding. Do they have a pacemaker? Do they have contact lenses, hearing aid, metal implants? Maybe they have GERD. They're not on a beta blocker. But maybe they had a previous surgery. If you enter the previous surgery, this information for this question will actually populate one of the blocks of the anesthesia workflow. You can also create, if you'd like, a COVID-19 block, where you could put in the patient's exposure and maybe their vaccine status if they have been tested. And as you can see, you can have children questions that flow underneath this, where you could put in a positive or a negative response. And we're going to say that they've not gotten a flu shot. Patient arrival time. In this case, we're going to enter that we want them to come in at 11 o'clock. And I entered this information. At some centers, I know the physician office calls and gives the patient the time. So that is an option there as well. And again, another questionnaire where you'll be able to give the patient the instructions that you have designed and you have set up. So you can see I have all my green checks and I have a 100%. And frankly, that is exactly what you want to see as a clinician finishes the workflow. The only workflow that may not be 100% is the physician workflow, as they may be waiting for a lab result to come back or their dictated op note to appear on the chart. Since we're talking about it, let's go ahead into that physician workflow. I'm going to log in here as the provider, and you'll be able to see that I am now in the chart as a provider. Each provider only gets to see their own cases on the schedule, and that is, of course, for HIPAA reasons. The physician can set it up so that the chart opens in their workflow. Here's the document display that we talked about and the H&P, which is still that hyperlink. Because this information came from Document Central, it's just going to have a purple triangle, which means you just need to confirm that that information is correct. Physician orders are designed to come in as a standard set. That set can contain standing orders if your center has approved these orders through the proper committees. It can also have PRN orders, it can have prophylactic antibiotic orders, and it is divided between non-medication or text orders and medication orders. The orders will stay yellow until they are signed by the primary provider. In this case, as is all physician workflows, the doctor signs all of the orders at once for all of the care areas. The system will disperse each of these orders to the proper clinician workflow so that each nurse does not have to read through all of the orders to make sure that they've captured all the ones that pertain to them. The system will do that for you. You'll be able to see here in the medications that the med check has been done, and we've gotten green checks for all of them, except lidocaine has given us a yellow triangle. The yellow triangle is caution. And that caution is saying that use of these Drugs must be approached with caution because there are several that in this chart that are all in the cane family, and it's letting us know that multiple canes could interact. You don't want to have too many of them. Now, the doctor is at liberty to change this order set before anyone signs them. But as soon as those orders are signed, they will not be allowed to change them. So the doctor will select all and apply his signature with one tap. Now you see that these orders are locked. In this instance, there happens to be a note with it. If you tap on the note, it will display that note for you. What if you signed it and now you want to change one out? For example, this pre-op testing, maybe he knows Lacey is not a diabetic. And so he'd like to strike through that order. He doesn't even want it on this case. He can just strike through it, just as you would on paper. Now that order will appear with a strike through here, and it will also be stricken through for the pre-op nurse. Let's go just a little bit further down. Because we have an H&P, and it is within the 30 days that this center requires, it will automatically populate that this document is here and it's stored in Document Central, and it will say that the doctor has examined the patient and they are still approved for this surgery. There are other options here. You can complete a block within this workflow for an H&P, or if you happen to be standing there with a paper copy of the H&P that has not yet been scanned in, you can select that there is a paper copy and put the date of that copy as well. But this is completed for us, so the physician is just going to have to tap and sign after he examines his patient. And then you're going to see the surgical consent. The system is designed to fill out a lot of this information automatically. In this case, it will leave you a blank for any additional information, and the physician only has to tap to sign. Now we'll notice the other people are not yet signed, and so we still have a red minus, and we still have, of course, that consent alert. But we've added a new alert up to the top called allergy. That is because I added that sulfa allergy a few minutes ago. Anywhere in the chart where you could order or administer or approve of medication, the allergies will appear in a red rectangle above the order grids themselves. So you always have your eyeballs on the medication allergies that this patient might have. The Lipitor that we entered in the home medication block automatically populated to the medication reconciliation block. And you can see it went through a med check as well. Most likely, the orthopedic surgeon did not order this Lipitor. The patient's primary surgeon did, so primary provider did. He's allowed to check that box and say resume as prescribed. You can also enter whatever dates, days, or weeks that you would like it to be resumed, or you can request that the patient not resume that medication. Discharge medications, from this part on downward in this chart, we are not going to complete it because the case has not started or finished yet. So we will get back to the physician workflow, and as you can see, it's at 50%. I'm going to just bring back up our nurse's workflow and proceed to registration. Registration is one of the few workflows in HST where the user must be both in the practice management to collect the money and approve all of the insurance information, and then they're in HST eChart to get some of the documentation signed. So we're going to start registration. This is the exact same block about patient information, with a main difference being the information that I filled in from the phone call has already updated this block. So as you can see, all the next user has to do Let's confirm that data. Here's that COVID-19 that we put in as well to approve and accept. If at your center you have registration complete NPO, this is where they would be able to do that in the NPO block. And as you can see, I got my green check. Now, anywhere this NPO block lives, whether that's in pre-op, anesthesia, the OR, anywhere you want it to live, the data will flow with this block. Here's the financial consent. The patient will sign directly on the touch screen of the tablet or device you're using. If it is not the patient, but instead it is their guardian, you're able to put that person's name here as well. But we're going to say it's the patient. And as you can see, it is date and time stamped. As the logged in user, I am going to witness it, and you can see my name and initials have been put on as well. Registration end. The next block is the staff block. This block filled in automatically based on who started this registration and when it ended. And as you can see, the block is complete without any action by the user. This is an important block because it fills the reports over on the practice management side for staff utilization and case costing. But as you can see, I have another 100%. Very often, registration is the place where someone will take a picture of the patient. I'm just going to pick one of my saved pictures, and we're going to save and exit. So now you can see anytime I open this chart, I'm going to have Lacey's image here for me, or in this case, Mary, as she would like to be called. All right, let's go into pre-op. So again, in pre-op, I want to stress to you that the order of these blocks, they should be stacked in the normal way that you would progress through a chart. That's important because you don't want to have to be scrolling all over to fill in a block. You want it to be a natural progression. So in this case, let's say the nurse goes out into the lobby and she sees the patient because she can identify them through the picture. She goes over and introduces herself, checks the armband, and then as they are walking back to pre-op, she checks the patient's NPO status and reviews those allergies with the patient. Maybe they pass by the scales and they enter the height and the weight of the patient. The system will automatically create the BMI, calculates that for you. And you can see it converted it into metric on the right. If you enter in metric, it will stick it in imperial on the right. We take the weight in kilograms and we put that in the demographics row up in the header because we don't want you to have to look all over the chart to try to find what that patient's weight in kilograms are for you to administer medication based on that number. Patient valuables. This block has a sister block, which is called return of patient valuables in the PACU area. But this is where you would say that you removed and kept with the patient their glasses, but they've given to the family member the purse. And the name of that responsible party was husband John. You can have the husband sign that he indeed took those. You can sign this as the nurse that this is what you did, or you can have another person who helped you lock that up. For example, a nurse's aide can sign as another user. But in this case, we're just going to have John sign off that he took the purse, and we'll let it stay there. Now we have the room in. So you can see I didn't put the room in first because we didn't room in first. But if at your center, the first thing that happens is somebody walks that patient into the cubicle, room in would then be your first block. So remember, you can order these blocks however you do your workflow at your surgery center for your patients. I'm going to say that we're in pre-op. I am still the receiving staff. I'm doing all the jobs today, which is important. This chart review is going to seem very long and cumbersome to you, perhaps because it's so much data that's coming in at one time. But I want you to remember that each user only stays in their lane and does their workflow and their job. So they really only have 10 or 15 blocks to fill out. In their workflow, they don't have to fill out all of the information in all of the workflows like I'm doing today. So here's that physician orders. Again, the allergy check is visible. We can see that the doctor signed them, except he crossed out blood sugar. And I'm going to read the rest of these and say that seems pretty logical and go ahead and sign off on them. We have a feature that's built in that's called hidden orders. In the background of this order set, we have hidden an order. And you'll see that order is clindamycin. And that clindamycin is not scheduled to be given unless the patient is allergic to the cefzolin, which they are not. So I'm going to go ahead and hide that unsigned order again and just keep it in the background. The system will get rid of the unsigned orders during the nightly job. Anesthesia orders work much the same way. In this case, the general anesthesia orders are selected. I'm going to go ahead and select all and sign it, and it will be marked complete because in my workflow, that's all that I can do. It still requires the anesthesia provider's signature. So this block will be incomplete in their workflow. Here's that consent for surgery. We're going to have the patient sign it. And then I'm going to purposely leave this unsigned. I would like to show you a feature that you'll be able to see here in just a minute. Vital signs block. Vitals can be brought in either by a monitor interface, or you can manually put in the vital signs. I'm just going to go ahead and enter a set for us to have. Our patient's a little nervous, so our heart rate's up and our respirations are up. She's at 100% and on room air, and her temperature is 98. If you come back in 5, 10, 15 minutes and you want to enter another, and it is almost exactly the same reading as this, you're able to do something that we call clone. And you can clone this row with the now time. And maybe she's just a little bit less anxious right now. And so her heart rate and her blood pressure are coming down a little bit. So you don't have to refill in everything. You can just clone off the first row and put in the second row. We also leverage the features of the tablet to be able to give you the opportunity to take an image of anything that you feel necessary. Some centers like to take an image of the 6-second EKG prior to going to the OR so they can look at that rhythm and have that normal sinus rhythm attached here. Or, of course, if there's AFib or anything else that they wanted to attach, they would. You can also use this feature. Let's say you're starting an IV on a patient and you wanted to capture an image of the torn skin or the bruise prior to insertion of the IV. You could use this and add that image. When you add that image, it allows you again to use the camera and add in a caption or a note to that image. I'm going to go ahead and select NA. Pain assessment is a cumulative block. What that means is whatever you enter here as your pre-op pain, you will be able to see in PACU what their trend was. So you'll be able to compare the initial value with the patient's current status. Fall risk assessment is a clinical decision support block. You'll be able to complete the fall risk assessment. Do they have a history of falling? No. IV access? Yes. Are they weak or impaired or use crutches? Well, she has a really painful knee. So we're going to say yes. And most people do tend to overestimate, and it's going to give them a medium risk. It's going to assign that risk and that number, and it's going to put that here. If we were a high risk, we would have a fall risk alert banner in the header as well. And then you pick out your interventions. And now we see home meds, right? The pre-op call nurse obtained this information for us. And now on the day of surgery, we're able to see it. And we can actually ask the patient when their last dose was, and they might say it was the night before, and apply it, and it's going to apply that last dose for me. That medical surgical history that we completed on the pre-op phone call is also here for my review. We have DVT, VTE risk assessment. This is the Cabrini risk assessment. You'll notice some of the information is filled in for you, basically the BMI of the patient. And if they were in either of these age brackets, it would also fill in for them. But this patient is pretty young. They will have restricted mobility for several days. So we're going to say that they do have restricted mobility and they are at a medium risk. If your center puts compression or sequential compression devices on every patient, regardless of their DVT, VTE risk assessment, you don't need to have this block on it. You just need to follow your policy. If there are any contraindications, you would put them in there as well. But we're going to pick compression stockings. We're going to do calfing, and we're going to do them on the non-operative side. Okay, great. IV insertion. We have two different blocks for IV insertion. One is simple. The other one is complex, which allows you to put in any missed attempts and who missed those attempts, and there's associated report. But we're just going to fill out the simple addition, and we're going to hang that normal saline. And I inserted it, and it's correct. And I'm going to get my green check. So I said that we put this in on the left wrist. So this block is called sketch pad, and I am able to circle on the left wrist where the IV is. If I missed any IVs, I could actually mark where I missed them. This would help the PACU team to assess the Band-Aids on the sites I missed and make sure that they understand where exactly that IV is located. Medication administration. To administer medication, you can select the top and administer selected, which will put in the now time and will save you from having to open the flyout. You can also select one, and you can have another user confirm that dose for you. So for example, if this was insulin or if this was a medication that your center required to be confirmed, another user can tap up here and log in their user ID and password. In this case, we're going to make it the doctor. He happened to be walking past, and I asked him to confirm that for me. And what you're going to see is a little check marks that this was confirmed, and that helps make sure that you're following your procedure and your policy at the center. So we're just going to check that off, and we're going to administer it. Now, if I gave the medication, I want to come back and administer it later. This is where you can edit the time. So I could say I actually gave this a little while ago and save it. Surgical site assessment. Is it intact? Do I need clippers? Did they perform any prep at home as they were instructed, a shower? And did the staff also perform the prep that they needed to? If your center gives discharge instructions in the pre-op area, then that's where this block will live. If you don't, and you give it in the PACU or post-op area, that's where this block will live. In this case, we put it in both so that you can see. If I review these instructions with the family, these instructions, this set is connected at the preference card level, at the procedure level for that physician. So all of your discharge instructions can be as very specific or as general as you choose, and you can combine them into a set. You can also add instructions on the fly. I'm going to go ahead and add my knee scope instructions to this list, and it's going to pop it in up here, and it's also going to pop it here. Now, any of these are immediately editable directly in this block. I can make whatever edits I want right here in this section. I can do that in any of the sections, infection control, general. We even provide a section for the physician to mark any special instructions that have to do with this patient. Once I've gone over these, I can review them with the patient. It's going to put my name and my review, and I can have that patient or their significant other to go ahead and sign that I have indeed reviewed these instructions with them. Patient status is a block that is associated with the patient locator, and it will let the other clinicians know that this patient is ready for them to go to the operating room. You can also have other statuses that you create, and they could be ready for anesthesia, ready for block, patient delay, ready for the family, ready for surgeon to mark. You get to decide what all of these are, and you can put them in this, and it will update the patient locator. Supplies used. Uniquely to HST, you can mark the supplies used by area. So the pre-op nurse can certainly mark the medications and or the other supplies. Now, we said the patient didn't need any hair removal. So I'm just going to delete that option. And we're going to say she doesn't need oversized. She just needed the regular. So I'm going to delete that option. And then all of the rest of these look good. I'm just going to confirm the supplies. Now, what if I say, oh gosh, I actually used 2 of these needles because I dropped one on the floor. Again, that clone feature comes in handy, and it will add a second instance automatically here of that new needle. Now, to send that one, all you have to do is tap confirmed. You don't have to uncheck or recheck. It will not resend items it's already sent. It also will not send 0 quantity items. Those items are, all of these items are sent directly over to PM inventory, where you can have it deplete automatically, or you can have someone review it before it depletes. We have a unique feature in eChart where I do not have to fill in the room out and the staff out time in pre-op. That's because very often in pre-op, you don't know exactly who came to get your patient or when, because you are, quite frankly, busy admitting another patient or 2 patients. So you may not see this. So we have a unique feature that in the next workflow, which is intra-op, the intra-op nurse fills in her room in time and her receiving name. It will populate all of this information automatically for you. So even though we don't have 100%, I'm going to go ahead and pin that chart, this workflow, and it's going to appear down here at the bottom. Let's go ahead to intra-op. So now that I'm in the intra-op workflow, you'll be able to see here at the bottom, I have pinned Lacey's current visit summary, and I've pinned that pre-op. So we're going to be able to toggle over to those anytime that we want. So let's go ahead and fill out the intra-op, and then we'll look back and see. So here's the same exact consent that we already saw, and not signed by the witness. And you'll see here, alert consents not signed. HST has 2 hard stops in the room in block. One is consents not signed, and one is H&P attestation. Now, we signed that in the physician workflow, but it's saying that the consents are not signed. So I'm going to go ahead and sign this. And you'll say, Mara, it's still not signed. Well, that is because in the anesthesia workflow, which we have not yet covered, you'll see that they also have a consent. So let's do what the anesthesia would have done prior to going to the OR. They'll review the documents, they'll review the NPO status, maybe in-house lab results. If we had done a urine for pregnancy, the results would appear here. The anesthesia history, they will have a bunch of questions that they want to ask the patient. And maybe this is an extremely healthy patient, except of course we know she's on Lipitor. So let's wait till we come down here. We'll mark her hyperlipidemia. And then we'll say that she has no other disease processes. And we're going to say that our anesthesia provider filled this in. Then they have their preoperative physical assessment, which they would also fill in: heart rate, respiratory rate, level of consciousness, their oral cavity, their dentition, caps, crowns, braces, fillings, any of that, their Mallampati score, whether they have any neck restrictions, their ASA class, what the primary planned anesthesia is, and any secondary anesthesia, such as a post-op regional pain block, and who this was performed by. Again, I'm going to say it's Dr. Brock. And here's our anesthesia consent. So anesthesia has all been addressed and everything's good. Yep, the patient's going to sign it and accept. The anesthesia provider is going to be over my shoulder. Let's let Dr. Brock sign over my shoulder. And you see, I didn't have to navigate away and navigate back and sign out, log back in. All I had to do is hand them my device and let them sign it directly over my shoulder. And now my consent banner has gone away. Okay, so we have your anesthesia orders, which we already reviewed. These haven't been signed yet by a nurse because they are PACU orders. And again, he would sign that in his workflow, but I'm not logged in as Dr. Brock. So we're just gonna go right over my shoulder and sign those. Great. Then we have anesthesia start time. Oops, let's put Dr. Brock in here. Since he is an anesthesiologist, he will not need a supervising provider. In fact, in your state, the CRNAs, if they practice independently, this section won't even show. That is a configuration setting we can make disappear. Prophylactic antibiotics has its very own box for administration. That's because many of our orthopedic providers like to track that pre-op antibiotic was given prior to tourniquet uptime or incision start. So we're going to go ahead and fill that up. And as you can see, that was med checked as well. And we have our allergies on top of that. We have anesthesia care. Apply those standard monitors. The neck is neutral, pressure points. The eyes are taped and padded and lubricated because this is general anesthesia. And then we begin the general anesthesia induction. I'm going to take this opportunity to go back to hopefully this is our chart current visit summary page. Let's see if it is. Nope, that's the pre-op one. Current visit summary. Now you're going to see the medications that we've administered so far. You're going to see the vital signs that we've accumulated so far, the home medications, the patient's address that we input, their allergies. Right now they're at a fall risk and they have a medium DVT, so that's getting put on their problem list. We still have their H&P and no in-house labs. So I'm going to go ahead and unpin that because we don't really need that anymore. And I'm going to go back into the intra-op workflow and see where we left off. I think we left off right here. So my warning is gone. Now that my consents have all been signed, I can go ahead and room in the patient. Built in the background is a late start study that you'll be able to enter the information about why the case is late and any comments that have to do with that. This is a feature you can turn on and off, so maybe you only want to do a quarterly or annual look at your late starts, but that is how you can do it automatically. eChart has a really cool feature called Quick Chart. It allows you, once you have roomed in the patient, to apply any of the non-patient specific information that is going to stay the same for all of your knee scopes that you do today. And I'm going to apply the Mara knee scope demo quick chart. And you see it's working. It's going to apply certain information that I know is going to remain unchanged throughout the day directly into the chart and save me from having to complete it. Now, how many did it fill in? All the ones with the blue triangles all down the row. So let's take a look. Pre-op diagnosis information. This came from practice management, so I'm just going to load that information as well. Wound classification, that came from Quick Chart. Patient positioning, that came from Quick Chart. Positioning aids, that came from Quick Chart. Thermoregulation, that came from Quick Chart. Equipment, that came from Quick Chart. Counts, no ma'am. If you do pre-op counts for your knee scopes, then you will fill in this block. If you only do a first count and then you could check no additional counts required, that's fine. If you don't do counts with your knee scopes, you can just NA that block, or you can build your chart without that block in it. Instrument sterilization. Quick Chart filled this in as well. It knows who my scrub is today and what my sterilizer is for this. They come from Central Sterile. My tourniquet. It's going to fill in as much of this block as it can. That the test and all of this information that I do on every single patient is absolutely done. But it's not going to fill in my uptime and my downtime. This is user-specific time that you're going to have to go ahead and say time up and save it. And then when the procedure is done, you'll come back and put the time down. And it's going to total your minutes on your right and your left. And why is there a right and a left? Well, some people are crazy and they do bilateral bunion repair on the same day. That would absolutely not be me. But that's why we allow you to have two different time ups and time downs. Fire risk assessment. It completed that for me as well because my fire risk is the same for each of these. This is one of those clinical decision support blocks that will fill out and give you that information and give you a score for it. So all I have to do here is accept that information. My intra-op surgical safety checklist will not be filled out for me. I must do that myself. And I believe we gave it at 15, 20, let's say 15 just to be sure. And then we have our timeout. This is a hard-coded block. The one above it, the surgical safety checklist, is a checklist that you create. You get to ask whichever questions your team has decided is part of their surgical safety checklist. Then you have the prep workbook. So this was completed by Quick Chart because it already knew I wasn't going to take care, and it already knew that it's going to be performed by me. So it completed this. Now, the actual name of the prep solution came from the preference card. So that will also fill in. Then we have incision start. Now, if I fill in incision start here, it will fill in incision start for anesthesia and vice versa. So you don't have to ask each other, did you fill that in? What time is it? What was the start time? All of that is in there. Again, we have the medications that the physician signed in his workflow, separated out to include only the intra-op workflow orders. And we have the medication, and these are a set because it wants that saline mixed in with that bacitracin. So we can administer the set together, and it will put the same time for that set. If he wanted another instances, I need more irrigation, you can reload that set, and you can give that second dose of that set if you want to, and it will populate for you. The solutions came from both the preference card and the quick chart. The amount came from the quick chart. We're going to go ahead just for fun, and we're going to change that because I want to show you something. And I just made that 11. We don't have any implants for this case, and we don't have any specimens. If we did have specimens, we could absolutely put them in there. Drains and packing, not going to use it. Equipment radiology, not going to use it. Now, if you have a different chart for scopes than you have for other orthopedic cases, you'd be able to build your chart without these blocks in it. Patient and procedure information, you load the actual procedure done. You can edit it. You can add to it. You can make a different procedure primary or secondary. That all can happen directly in here with the plus button. You can add a new one. If you don't know CPT codes, that's okay. You could type in the procedure description and it will populate just as easily as it can without the CPT code attached. And then you have incision stop. The dressing, again, the dressing will populate from your preference card to automatically put in the information for the dressing that you want. And the quantity will change, tape 11. So we're gonna, that's how it comes packed. So we're gonna remove that one because we didn't use it. When I remove it from here, it will remove that item from supplies used, but it will also add that weird 11 for normal saline that we added. So updating the blocks will automatically update the associated supplies in the supplies used block. And then you're able to confirm or deny by just going right down them. If you have a hold item like this one, you could still confirm the supplies, and it's just going to drop that completely off the list. Makes sense? Great. All right, here's our room out. Again, I'm going to leave this blank. The pre-op room in time, I'm sorry, the PACU room in time is going to update this automatically for us. So let's pop back over here. And we're going to take a final look at the rest of the anesthesia. We got right here to induction. We're going to say we used an oral airway, that the LMA size we used was 2.5, and it was none of these traumatic events. If it was an ET tube instead of an LMA, you can select that it was an oral ET and pick the size tube that it is, what it was, where it was taped at, and what kind of blade you used. This is a list that you create of your blades at your surgery center. But again, I'm just going to go ahead and pick the LMA size. The intraoperative graph. This is the graph that anesthesia providers are most used to filling out. If you change the primary anesthesia type, if we changed this to nurse monitor, it would change it up here to nurse monitor. If we change it back to general, it will change it up here back to general. So any changes that you make will move forward or backwards with this chart. Okay. The gases and the medications that appear here are preloaded for you based on the chart type. In this case, we have O2 and SIBO, and we have a bunch of medications. But we give you the opportunity to manage those directly on the fly. So let's say I like to see the end-tidal SIBO as well, and I would like that as part of mine. I can manage it on the fly, and I can manage medications the same way. I can add different medications on the fly that I want to see in my view of this record. I can also administer medication set. So Dr. Brock has his own induction set, which has the propofol and the lidocaine, and I'm going to administer that set, and you can see it populates both of them together and it totals them for us. If you have a propofol infusion or any type of infusion, you can also create that by dose, by kilogram, by time. And you're able to say, I want to give it in micrograms per kilogram per minute, but I would like my totals to be in milligrams because I don't want that microgram enormous dose number looking me in the face on the end of it. So you can change that as well. And then you could just put in your start time and save it. It's going to start with, and that line will continue until you stop it. You can change the dose as you move along. You simply have to go back here and change that new dose and put in the new dose that you want to give. And it will carry on the new dose and it will continue to calculate the total. EBL populates the operative report. IV fluids and urine output will populate the intake-output block that's in the PACU workflow. So you can see intake, IV, and normal saline were already pre-selected. That is because that's what I started when I started the IV, so it knew and it filled that amount in for me. But I'm going to say we got 200 at that point in time, just so we can have something to look at. Okay, let's go ahead and look at the crowning jewel, which is the IV vital signs. They can pull in by a monitor interface, as we discussed, or the user can drag and drop those vitals directly onto the green line, which is the Now button, and you're able to put those numbers exactly where you want them to be. And it will continue to track and trend this across the entire continuum of care for you. You can add a note, and perhaps your supervisor might want to say present before induction. Those can be obvious answers. When you hover over it, it's going to tell you what that note says. Below the table and the graph are the grids. The grids will show exact information that you have put in. You didn't enter any event settings, but it will put in all of that information for you. And of course, any of the anesthesia providers taking care of this patient are able to sign here that they participated in that care. Now, I'm going to go up here and stop my infusion because we're going to move on, and I'm going to forget to do that, and this patient might receive an excess amount. Okay, so we have anesthesia stop time, which may or may not be the same as the room out time. Depends who's taking that patient over to PACU. At my center, it was the anesthesia provider. So who they handed off to, what problems, if any, existed, there's your handoff. Here's your post-anesthesia assessment. You can even put in a read-only version of the PACU vital signs so that your anesthesia provider will know what the vital signs were in PACU. They can add any kind of notes if they see fit. You can even include your anesthesia MIPS if you want to trend or track that through the HST chart. And then the supplies used for anesthesia as well. Okay, let's go to, this is the pre-op workflow. And as you can see, as promised, we have 100% And that is because the staph block and the out block filled in automatically. Just wanted to show. Let's go over to PACU. So we're going to say room in time, and the patient is in PACU phase 1. I'm very busy today. I'm the receiving staff as well. Patient came to us by stretcher. I'm going to mark in the post-anesthesia airway following my ABCs. And let's just say they're on 6 via nasal cannula, and the breath sounds are clear, unlabored. Patient could take a deep breath, and we're not going to do that incentive spirometer on this patient. And we're going to save and exit. And we have the pre-op vitals if I wanted to compare. And here we have the post-op vitals. And again, I'm just going to enter a few vital signs. All right, so we have all the vital signs in there now. We're going to look at the pain assessment, and as promised, you can see that pre-op value. And right now we're going to say that the patient is resting or asleep, and we're not going to bother them until they wake up and ask them that. Extremity check. We did have a left knee arthroscopy, so we're going to look at their left lower limb. It is still pale and cool, and maybe capillary refills are a little slow, but have good pulses, and they are having some tingling, limited movement, mild swelling. You don't have to do the strength unless you're doing neuro checks, in which case you're welcome to do that. But it's going to fill in that extremity check for me. And now we come to the modified Aldrete. We have kind of a neat trick for the PACU girls. They could put in the time of now, and they could ask it to use the latest values of all the blocks that I just completed. And it's going to populate a great deal of the modified Aldrete for me. For example, able to move extremities, it only gave a 1 because I said it was limited. In the extremity check, deep breaths and coughs, it gave it a 2 because I gave it a 2. In my airway block, systolic pressure against pre-op values. I don't have to have that pre-op block in this workflow for it to do its magic. The system will go back to pre-op and check against the pre-op value to see what the difference is. But I do have to say whether or not the patient is fully awake. And then, of course, they are on O2 at this moment, so they gave me a 1 for that, and I got a total of 7. Now, when you come back the second time through and you fill in those again, you could have a very different value here. But let's say that you just want to do the Aldrete score a second time or a third time. You can clone it like we talked about, or you can enter a new one of your own volition without using any saved values. Patient safety measures. This is a block you can or not use. Patient education is saying these are all optional blocks. Anesthesia orders. These are the PACU orders from anesthesia. We're going to go ahead and select those and sign them. If your anesthesia has a protocol for its secondary or tertiary line of anti-nausea or pain medications, you can add them as hidden orders behind the scenes and just bring them forward as you need them. The physician doesn't have any orders for me in PACU. Well, that's interesting. But you can add that discharge order when the patient is ready for discharge. These are the medications that came from the anesthesia orders. And as you can see, those are all PRN. So I don't have to give them to get my green check, but it's letting me know these are available with the instructions that the physician gave. Drains and packing. If you have any, you put it in there. Dressing assessment. Now, I've been asked a lot, why doesn't the dressing assessment tell me what dressings were applied? Excuse me. And that's because most of the time, PACU can only see the top layer of the dressing. So it's the left side. Right now, there's moderate amount of watery discharge. soaking out through it. There's no bleeding. And right now we're just going to watch it and see what happens. It asks for my site. And it is the left knee. Okay, intake and output. There's anesthesia's line. Yay! And you can add your own and it will continue to total. So maybe in PACU, it was the total of that IV fluids and you see it filled it in as well. And maybe there's 800 gone. And you can do a urine output and anything else as well. And you see it's gonna, I will not check unable to measure. I put in a value. But you can say unable to measure, which sometimes comes in handy for urine analysis. It's going to do it again for me. Anyway, this is IV site image capture, right, that we did in pre-op. We started there and missed it, and here's where it was. So they'll be able to just continue that IV knowing exactly where it's at. Your discharge plan, very simple, easy to fill out. Medication reconciliation. The physician filled this out for us. We're not giving any prescriptions on discharge, and so we're good to go. Here's those discharge instructions, right? They were in pre-op. Here they are again. If you needed to make any changes to them, you could absolutely do so. You'd have to have the patient unsign, make those changes, and then they could re-sign those orders for you. Patient status, ready for family, ready for discharge, whatever status you want to pick out. This list of home twos, this is CMS's list. We don't have control over that, but we default it to home. If you transfer this patient, we have a transfer block you can use along with many other tools, but we're going to say discharge time, discharged by me. Again, I'm very busy today. And we took them out by wheelchair in care of John. And because I filled out the discharge status, it already automatically filled out that out time for me. The quality metrics are required by CMS now. So we have popped them in the chart to make it easy for you to follow. Did the patient have any of the following during this visit? Did they have a fall, a burn, a wrong? I'm going to say no, but you're going to notice it added something here. It added that they did not have a burn, fall, or wrong event, like I put in, but it also says it did not have a transfer hospital because that is what I selected in the block above it, discharge status. This has a report that you can pull over in practice management to help administration complete the CMS quality measures that have to be submitted to their website. And then supplies used. Some people don't have a lot of supplies used, but if you have a boot or Band-Aids or whatever you have that you send that patient home with, if you build it in the preference card, it will automatically populate in this field. So we're going to pop back to finally to that physician workflow. One good thing about eChart is that there's no save button. So the system saves every single field as you complete it. And it doesn't save it on the device you're using, it saves it to the database. So why is that important? A, the devices is not going to leave you open for HIPAA violations if it leaves your facility, because there's no data saved on that device whatsoever. And secondly, I completely forgot where I was going with that, so we'll delete this part. So here's your medication reconciliation that he finished. The interim operative report or immediate post-op note, whatever your center calls it. If there's not going to be an operative report on this chart before the patient gets to PACU, they have to fill this in. But in saying that, it's very easy because we populate every field automatically for them. So all they need to do, if you had specimens, it would show here. Implants would also show here. We even check findings as expected. If they are complications or different findings, they uncheck this and they add whatever they want to add. But they are required to sign that if they're not going to have an operative report on the chart when the patient arrives in PACU. And that's so that if they are transported, you can send all of this information with the ambulance driver to the change of facility place. The operative report, again, a lot of this data is going to fill in automatically from what the circulator completed, from what anesthesia completed. All of that information will populate right here in this top part of this block. If your doctor dictates an operative report, it will be here as a document link, much like all of the document links in eChart. However, if they would rather use a template to complete it, they can create templates that have all of the stuff they usually do here, and they're able to edit it, change it, add to it. The third way that you could get information into the operative report is via voice recognition software. So if you have voice recognition software on your device, like Nuance or M-Modal, you're able to activate that browser bar extension and pop your cursor in here and dictate just as you would in your office if you were using your Dragon or your M-Modal voice recognition software directly into this square here. If it is an attached document, it will come in as signed or unsigned. If it comes in signed, the block will complete itself automatically. If it comes in unsigned, it will generate a task for the physician to complete when he or she logs back in. So I'm going to go ahead and sign this. If you send out labs, the lab results will appear here. It will also trigger a task. Now you've heard me say trigger a task a couple of times. So let's go back here to the login screen. And you can see we have search. We have the patient locator that we talked about, which tells you all kinds of information, including who's taking care of the nurse, what their anesthesia time, where they are in the continuum of care. But we also have the task manager, and that will bring you a list of charts that you have worked on that are not complete. So every single night, the system goes through each of your charts, finds every required field that is incomplete, and assigns that task to the most likely user. The most likely user in this case is the orthopedic surgeon, and these are the tasks that he did not complete. And if we tap on them, it'll take us directly to that workflow, directly to that block that has not been complete, and require the physician to complete that workflow. And once they do and they tap on the HST icon, we'll bring them right back to this screen, and each one of these will drop off the list. When they're finished, they get a nice trophy that says you're all done. So Task Manager is a very important, helpful tool. And the other thing I wanted to show you is in the chart home, you can also see the previous visit summaries. You can see the clinical notes. You can see outside and patient portal data like from OMP, One Medical Passport, and you can also see internal information from HST's patient engagement. And if your prescribing physician has jumped through all of the credentialed hoops, you'll be able to enter in a prescription directly from HST eChart. This concludes our review of the orthopedic chart in HST eChart, and I hope that you've had as much fun listening as I've had explaining it to you. Thank you so much.